Module Overview. The foundation of effective infection prevention and control. IPC systems lies in robust surveillance and monitoring mechanisms. Surveillance serves as the eyes and ears of IPC programs. It enables healthcare facilities to detect outbreaks, monitor trends, evaluate the effectiveness of interventions, and comply with national and international reporting obligations. In the wake of the COVID-19 pandemic, healthcare systems globally have realized the critical importance of early warning systems, real-time data analysis, contact tracing, and interdisciplinary coordination in outbreak management. This module deeply explores the principles and practices of active and passive surveillance, routine monitoring, data-driven decision-making, epidemiological tools, and emergency response planning in line with updated guidelines from WHO, CDC, ECDC, OSHA, and national IPC authorities. 1. Foundations of surveillance in IPC. What is surveillance? Surveillance in IPC refers to the continuous, systematic collection, analysis, interpretation, and dissemination of health data related to infections within a healthcare setting for the purpose of planning, implementing, and evaluating IPC measures. Types of surveillance. 1. Type 2. Description 3. Example. Use cases. Active IPC team actively seeks data via ward visits, audits, chart reviews, investigating surgical site infections, SSIs. Passive rely on staff to report data voluntarily. Routine reporting of COVID-19 symptoms. Targeted focuses on high-risk areas, pathogens, or procedures. ICU ventilator-associated pneumonia. VAP universal monitors all infection events across entire facility. All HAIs in a tertiary hospital. Sentinel monitors a subset of locations or patients for early detection. MRSA surveillance in long-term care units. 2. Monitoring infection trends and incidence rates. Core metrics. To track, HAI incidence rate equals open parenthesis. Number of new HAIs divided by total patient days, close parenthesis, times 1,000, device-associated infection rate equals open parenthesis. Infections divided by close parenthesis, device days, times 1,000 hand, hygiene compliance rate, antibiotic resistance, trends, AMR tracking, environmental contamination levels, data collection tools, electronic health records, EHR, IPC audit checklists, case investigation forms, laboratory reporting systems, mobile apps for real-time reporting facilities should benchmark data against national surveillance systems, e.g. NHSN in the US, ECDC in Europe. 3. Data analysis and feedback. Analysis techniques, descriptive statistics, e.g. frequency, rate, trends over time, root cause, analysis, RCA, for individual infection events, control charts and outbreak curves, dashboards for visual summaries, comparative benchmarking with peer institutions, feedback mechanisms, weekly IPC team reports, infection control committee, ICC briefings, staff bulletin boards, incident review, meetings, public health notifications. Regular feedback helps build a culture of accountability and transparency. 4. Outbreak detection and management. What constitutes an outbreak? An outbreak is defined as an unexpected increase in the number of infection cases, either in a specific population, setting, or time frame that exceeds the expected baseline. Examples: 2 or more cases of MRSA in a ward within 7 days, a sudden spike in norovirus infections in elderly care units, detection of multi-drug resistant tuberculosis, MDR-TB, in 2 unrelated patients, steps in outbreak response, detection and reporting, early recognition via surveillance, notify IPC committee, and authorities, outbreak investigation. Case definition, line listing, epidemiological linkage control, measures isolation and cohorting, environmental decontamination, restriction of admissions/visitors, enhanced PPE use, communication staff briefings, public health alerts, press releases, if needed, post-outbreak review, identify system failures, update SOPs, train staff based on lessons learned. In many jurisdictions, outbreaks must be reported within 24 hours to public health agencies. 5. The role of IPC teams and committees. IPC team responsibilities: conduct regular surveillance rounds, analyze and interpret data, initiate outbreak response, provide training and feedback, liaise with public health bodies, Infection Control Committee. ICC duties. Governance of IPC program. Approve policy changes. Monitor outbreak response effectiveness. Support infrastructure improvements, e.g., negative pressure rooms. Accreditation bodies now require proof of active IPC governance, meeting minutes, and data sharing protocols. 6. Post-COVID digital surveillance innovations. Contact tracing apps with Bluetooth/GPS, integration AI-powered infection, prediction systems, machine learning algorithms for HAI pattern recognition, QR-based bedside IPC, reporting tools, integrated lab surveillance systems with instant alerting. Learning outcomes, Module 8. By the end of this module, you will be able to explain the types, goals, and methodologies of infection surveillance in healthcare, analyze data on infection trends using accepted metrics and tools, apply best practices in outbreak detection, control, and documentation. Understand the critical roles of IPC teams and committees. Integrate surveillance with digital health tools for rapid decision-making and accreditation compliance. Accreditation compliance and CPD alignment. This module is aligned with WHO core component. 4. Surveillance, CDCN, HSN protocols for HAI. Surveillance Joint Commission IPC accreditation standards. ECDCs, Healthcare Associated Infections Reporting Framework, OSHA, and Public Health England Outbreak Guidelines. This ensures CPD certification readiness and strengthens institutional eligibility for ISO 15189 JCI or local regulatory accreditations.